afternoon, everyone. My name is Zahy Abou-Atme. It was actually quite close. I didn't mean to sound that it was deviating. I'm an associate partner with McKinsey Company within the healthcare practice. I primarily serve payers, providers, private equity firms. And we're often asked about, especially recently, how to think about MSOs and how to enter the space. The typical consultant answer is going to be, it depends. But what I'd like to do today is offer a few of the perspectives that we think about whenever different payers and providers are thinking about entering the space. So I'll just start out with a brief overview of our perspective on the MSO services landscape. It's obviously wide and varying. We'll go from there to think about the evolution of the space and how to think about the different challenges in the market and potential paths forward. So, characterizing an MSO market can often be difficult. It ranges from pure administrative services to clinical services and patient engagement services, and then also decision support layered on top of that. Despite the variation there, the services will typically fall into one or more of the categories over here. Within that, though, there's obviously multiple options. For instance, you might think about your contracting as being full risk, partial risk, administrative fees only, depending on the circumstances. And there's obviously significant variation in care management processes as well, which can oftentimes make it difficult for a payer or provider to compare across different MSO companies. And also making it difficult to think about, just given the fragmentation in the market, how do you scale the capabilities beyond one state and another? I think the previous presenters were also talking about challenges in integration in the market, and that's definitely being felt by some of the payers and providers that we're talking to in terms of how do you actually think about scaling the distinctive capabilities they're seeing in one market beyond that state. So what tends to happening is that organizations will tend to fall in one of two main archetypes. Historically, in California, there was a surge of the MSOs that tended to own and operate their own clinics and have their own MSO services. Sometimes they would outsource the administrative services, and sometimes they'd build them in-house. And that largely was driven by Kaiser there, obviously, as a catalyst. And what the MSOs offered there was a way to compete in the subcapitated market as the market there was more primed for it. And this was driven obviously by decades of priming the market and technology services that helped drive this forward. Nowadays, and more recently, the managed services type of organization is what has been kind of growing and scaling and capturing attention of several private equity firms. And they'll have an easier time, obviously, scaling, just given the lower capital requirements to do so as they go from market to market. But from a payer lens, they'll look at the clinical-based services as sometimes being a little bit more intensive in terms of the number of touch points that they have with their members and patients, their ability to drive down costs and influence providers. For an MSO looking to grow, finding the sweet spot between capital deployment and people is often a market by market decision. So when we look at that, we typically look at what are the characteristics of that state in terms of the payer dynamics, provider dynamics. Is there a presence of an integrated system that has a large market share in that space, and what is that going to do with the willingness to uptake? Folks are talking about physician-owned practices in the smaller end of the scale, and their willingness to kind of convert into more risk-based models. I think for the most part, providers have been actually getting more excited about the risk-based models, particularly driven by some of the more lucrative reimbursement models being driven by CMS and other companies. And so there is that higher willingness to convert, but there's always going to be the kind of at the lower end of the scale, smaller practices tend to want to stick to the fee-for-service model, making it harder to negotiate with them. The other piece to note just on clinic-based services and the way that managed services differ is their ability to kind of drive optimization of the clinic practices. And so in more intense integration with the providers, you tend to be able to deploy more levers around having people operate at top of license, getting the nurses to do kind of initial screenings, and then only dropping the care management team when you actually feel like there's an at-risk population that needs more intensive care. So it drives a bit more of the efficiency there as well. If you look around, there's obviously a degree of variation on that integration scale, right? The higher up on the integration, the more likely you're going to see ownership of the physician practices as opposed to just a contracting relationship. You'll see more at-risk components driven by quality metrics and clinical metrics like readmission, CAPS, utilization scores, and so on. But there is a chunk in the middle which have recognized that they need to kind of have a bit more of a bimodal approach to the market, right? So in some cases, they decide it makes sense for them to own and employ the physicians, and in other cases, they're actually thinking about it as a bit more of a contracting relationship and taking a bit more of a varied stance by market. Now, a few of the presenters already highlighted a few of the challenges in the industry. I won't read through the full list, but just to highlight a few, and some of these are a bit more from a payer or provider lens or an integrated system. The first is just around fragmentation and standardization, right? So we talked a little bit about this before, but the scale of many of the organizations today, while growing, and there's definitely this appetite for continued growth, is still largely fragmented. I mean, we're nowhere near where the physician EMR market is today, where top 3 players occupy about 50% of the space. And so there's definitely this recognition that there's probably more to be done over there, particularly around standardization. Because the ability for a payer to actually think about the different players in the market or actually partner with one in a specific market and think about how do I scale this to different states is sometimes limited by the presence of that MSO in multiple states. So there's definitely a need for more of that, at least from the payer side. The second is around scale. There's a few factors I highlighted before that come into play here. So one is the appetite of the physicians in different markets to enter into those kinds of relationships. The second is, the higher you see a Medicare Advantage penetration in each of those markets, typically that means it's a more favorable location for these kinds of capitated models and MSO arrangements. Obviously, the availability of a payer partner and the willingness of that payer partner to enter into those arrangements. In some cases, it may be hit or miss depending on the regional payer at stake and whether they're deeply entrenched in that market. And obviously the capabilities of that MSO and actually being able to transform physician practices that are in new markets. The good news is that payers generally are actually starting to move in this direction. I had an actuary friend a few years ago who told me that care management was nothing but an administrative services fee and something fun for consultants to play with. I think nowadays the recognition has actually come that there is an ROI associated with it, and typically, people are looking for a 3-to-1 ROI on care management. Otherwise, it's not worth it for them to enter it. But the sophistication of a payer to do the care management process by themselves is usually somewhat limited. They tend to focus more on the approaches than on more advanced prevention. But we know that it's there, and I think the reason that we know that it's there is that there's frequent examples of MSOs and the like actually helping prevent folks from entering end-stage renal disease, for example. AI starts to become much more important in that space as well, using genomics and other tools to be able to predict that using data. Starting to help some of the higher risk populations with medication management. Diabetics with, patients on dialysis can end up being on more than 10 medications, and managing that can tend to be very difficult. So how do folks actually keep up and actually ensure that medication adherence? Readmission is obviously another area that folks have been tackling. In some states, our research has shown that some providers tend to forget to do the proper discharge planning process for about 10% of patients. And you're seeing MSOs actually fill that capability gap, ensuring a follow-up and a smooth transition afterwards. Usually the first 24 hours after a discharge, people are euphoric, they're back home, but then they kind of forget what their doctors told them. And so getting that adherence is helping reduce the readmission rates as well. So, the challenge, here going forward is how do you get even, beyond what payers are now starting to see as the new normal for some of these services, right? So getting below 200 admits per thousand in some cases is actually already being achieved, but actually getting to sub 100 is the next challenge in some people's minds. And obviously that'll take a new set of capabilities. So what are some areas that we see kind of as opportunities for MSOs? There's obviously numerous, and the growth is still there, so the market has not yet matured from our perspective. So in the context of, from a capability lens, if we were going to take a look at what else do we see as capabilities that they can build that can really drive value for payers and providers? For the space of AI is one that we already talked about. The technological kind of enablement of many of these services has rapidly increased over the past few years. We think AI and artificial intelligence is going to be enabling the next wave over there and better data integration. There's a piece around home health. I think there's large recognition that the home and care at home is going to be a big shift. And so how do MSOs actually think about enabling that market, which can often be very difficult to manage with all the different providers in a market, and particularly around more difficult services, right? So getting into home infusions, which number one challenge there is getting patients to agree not to go see their oncologist because it gives them comfort. So how do you actually get beyond some of the barriers there that are inherent in home care, including home dialysis and others? I think one more, excuse me, that I would highlight is Medicaid. As far as we can tell, nobody's really cracked the nut yet on managing Medicaid costs down, and the ability to do that for a payer is going to be, I think, hugely valuable for multiple payers that are looking at this space. It's obviously a very challenging space just given the reimbursement levels and the conditions that people are encountering there. So it would take somewhat of a new set of capabilities to do that at scale, and again, have that positive ROI from a care management perspective. One last thing I would highlight is payers and providers are actually themselves thinking about launching MSO services in different markets, right? And so what does that actually mean for the independent MSO spaces? What we find is that they will do so in the context of trying to retain competitive advantage in certain markets, or try to defend their revenue streams in the cases of hospitals. There's going to be issues with both sides of that. We don't think it's going to, they may be able to do it in isolated instances, but their ability to scale up their capabilities quickly enough to demonstrate value in those communities may in some cases be hampered. And that's another area where MSOs can actually think about, from an agnostic services provider perspective, how can I come in and be sort of the mediator in that relationship between those payers and those providers? Or how do I think about white labeling my services more effectively so that payers and providers can also participate? That's all I had for today. I want to keep it short, even though I'm second to last presenter before lunch, but open to any questions that you might have. Great. I'll be around in case anyone has any questions. Thanks, everyone.